Jagdish, am I audible to you? जगदीश, तेरा आवाज मुझे नहीं आ रहा है जगदीश. यस यस. आया बीच में नहीं आया था, मैं बोला ना.
Yes. Okay. Good evening to all of you. On behalf of Lupin Oncology, I once again welcome all my distinguished faculties for the today's evening symposium. My name is Dharmendra. I head Lupin Oncology India business. Just to mention, Lupin is the third largest Indian pharmaceutical company by global sales, and we are eighth largest generic player globally and the third largest as far as US market is concerned. It's our privilege to be part of today's scientific symposium, that is recent updates in management of metastatic colorectal cancer. I think with this, it's my pleasure to invite Dr. B.K. Smriti, who is the program director for today's evening symposium. Dr. Smriti is a senior consultant medical oncologist and hematologist at Lilavati Hospital, Asian Cancer Institute of Bombay Hospital, Mumbai. She is a core faculty of European School of Oncology, Invited faculty of ESMO Asia Congress 2017, committee member of Breast Cancer ESMO Asia Congress 2020, International Panel of Experts on Advanced Breast Cancer APC 2017 and 2021. Ma'am have been a part of various associations like Mumbai Oncology Association as an honorary secretary and as a part of ISMPO. She has authored various publications, almost 1,000 plus reads and more than 30 scientific papers. With this, I would like to invite once again Dr. B.K. Smriti to take the session forward. Ma'am, over to you.
Thank you for that kind introduction. I would like to welcome you all to this meeting of metastatic colorectal cancer. There has been a flurry of new options which have come up as a result of a better understanding of the biology of the disease and more targetable mutations that we find in the disease. And so there has been a sudden advance taking place in this form and several other new first-line therapies. So with all this happening, I thought that we should have Dr. Charlene Gill to actually apprise us of all this and what is the current status of affair as regards all these new therapies. So with this, I welcome you all to this meeting, and I invite my chairpersons, Dr. P.N. Mahapatra, who is the Director of Medical Oncology at the Apollo Green Eagles Hospital, Calcutta, and Dr. Sunil Kumar Gupta, who is the Senior Consultant Medical Oncologist at Venkateshwar Hospital, New Delhi, to chair the meeting. And I'm very glad to have both of you here. And thank you for taking time out to chair this meeting. Over to you.
Thank you, Dr. B.K. Smriti. Today we have a renowned international speaker, Professor Charlene Gill. Dr. Gill is a professor of medicine at the University of British Columbia and a medical oncologist specialized in gastrointestinal malignancy at BC Cancer, Vancouver. She received her BSc in pharmacy and an MD from the University of British Columbia in 1996, followed by residency in internal medicine and medical oncology. Dr. Gill subsequently completed a fellowship in GI oncology at the Mayo Clinic and Masters of Public Health at the Harvard School of Public Health. In 2017, she completed her MBA at King's Flagler Schools of Business, University of North Carolina. She is actively engaged in education and research with over 100 peer-reviewed publications and book chapters to her credit. Professor Gill currently serves as the chair of the Canadian Clinical Trial Group of GI Disease Site Committee and is president-elect of the Canadian Association of Medical Oncologists. I would like that Dr. Gill will highlight the molecular strategies treatment option in a metastatic colorectal cancer. If you see that colorectal cancer is the fourth most frequently diagnosed cancer in the United States, and in 2020, more than 1 lakh cases diagnosed from colon cancer and more than 43,000 cases diagnosed from the rectal malignancy. And combined mortality, they have reported more than 53,000. But in last 1 decade, if you see the pattern of colorectal malignancy is changed. Instead of old days, we are having a young patient more, and the tumor biology is different and the treatment options are different. And today we are having a more molecular targets and biomarkers for colon cancer. Today we are talking about NRAS, BRAF mutation, we are talking about MSI, MMR, and we are talking about the NGS. Today we are having a panel of NTRK, which will definitely change treatment option in colorectal malignancy. Today, the Dr. Gill will highlight regarding the molecular strategies treatment option in metastatic colorectal cancer. I would like to call Professor Gill for his expert opinion and presentation. Professor Gill, please.
Thank you very much, Dr. Gupta, for that kind introduction. I'm just going to share my screen here. All right, I hope you can see that. So, thank you again for this invitation. I'm really delighted to speak to you today about the changing landscape in colorectal cancer. My practice space is in Vancouver, which is in the west coast of Canada. And really, it's a timely discussion. As Dr. Gupta said, we are practicing in an era now where we are seeing a shifting epidemiology of colorectal cancer. Many of us have younger patients in our practice, and an improved understanding and actionability of the molecular biology of colorectal cancer. These are my disclosures. And in the next 30 minutes or so, I'm hoping we can kind of look at the current treatment landscape of metastatic colorectal cancer, review a bit the role of testing strategies and emerging biomarkers, and review where we're going in terms of biomarker-driven approaches in the treatment of MCRC. When we think about metastatic colorectal cancer, we recognize that in our practice, this represents a significant burden of the disease that we see. For every 100 patients diagnosed with colorectal cancer, it's estimated that about a quarter will have synchronous metastases at the time of presentation. And for those with early stage disease, a meaningful proportion of them, unfortunately, despite surgery and adjuvant chemotherapy, will go on to recur with metastatic disease. Once a patient has metastatic disease, there is a proportion of patients who may have oligometastatic disease, particularly liver-limited disease, that may be amenable to either immediate resection or potentially be resectable. But the vast majority of patients that we treat still have unresectable metastatic colorectal cancer. And we always remind ourselves that the goals of care in those patients is not only to improve survival, which really is the primary endpoint that drives a lot of the advancements, but to also improve quality of life, control cancer symptoms, and improve their experience of living with cancer. So when we think about those goals, we have to balance the treatments we have, and we also think about tolerability, and that's something we're going to talk a little bit about, and really, I think, is the promise of precision oncology, really about trying to identify the right medication for the right patient, at the right time to try to improve that therapeutic index. Conventionally, this has been our toolkit for those of you who are medical oncologists. 5-fluorouracil is a tried, tested drug of not only historical relevance, but very much relevant in our daily practice. Irinotecan and oxaliplatin, those form the backbone of our cytotoxic armamentarium. Within the fluoropyrimidines, we know we also have access to oral therapies, which are very helpful from the perspective of patient convenience and tolerability. And certainly in the era of COVID, where we have been trying to minimize patient visits to hospital, we've leaned heavily on oral fluoropyrimidines. In North America, the primary one is capecitabine. In the rest of the world, we see the use of UFT, tegoprurouracil, and S1, particularly in Asia, which is a combination of tegoprurouracil, dimericil, and otericil. So combining DPD inhibitors with 5-FU prodrugs. And in terms of biologics, for many years, we've leaned heavily on two classes, anti-VEGF and anti-EGFR. And once patients have exhausted those treatments, we've kind of entered the realm of chemo-refractory disease, where the two approved agents in the FDA and Health Canada currently are regorafenib and trifluridine tepracil. And those sort of incremental changes over time with the introduction of new therapies has led to improvements in overall survival. And this is a sort of a nice, it's not a direct comparison, but if we think back to 20 years ago when I trained, and the the red line represents the advanced colorectal cancer meta-analysis from 1992. We quoted a median survival to patients with advanced colorectal cancer of about 12 months, and that was based primarily on 5-FU therapy. A more contemporary reflection of expectation of median survival comes from the CLGB 80405 trial, now 5 years old already, but in that trial, the median survival for patients with RAS wild-type disease was 30 months. And that has kind of set the benchmark in our conversations with patients about expectations of prognosis. So we know there have been advances, but in GI, especially in metastatic colorectal cancer, it hasn't been one single advance that has made that leap forward. It has been slow, but meaningful incremental improvements, typically through the introduction of newer systemic therapies. I'm going to focus my discussion on the molecular approach, but I think just to remind ourselves of some foundational principles with respect to chemo. Chemo is still very important in what we do, even as we talk about novel therapies. And I think we all kind of accept a few sort of facts, if you will. In the palliative setting, a doublet is a doublet is a doublet. I don't think we waste much time these days choosing or debating which doublet or sequencing of doublets. I think we accept that that can be very much patient and provider choice. Most patients can tolerate combination therapy, but if we had to do sequential therapy for our patients who are older or more or have more comorbidities, that is also an acceptable approach, reminding ourselves what is the goal of therapy for that given patient. And chemotherapy breaks or holidays or de-escalation is also possible. We've really not been able to demonstrate a clear survival benefit for treat to progression continuous chemotherapy versus a maintenance sort of de-escalate or a lighter chemotherapy version versus chemotherapy holidays. So these are conversations that we have with patients, often dictated by their preference, and really the best response that's been reserved that gives us a sense of, you know, what is the disease's sensitivity to chemotherapy. And so now, you know, really focusing in on, you know, the 21st century and talking about precision oncology and metastatic colorectal cancer, you know, we have largely relied on patient characteristics, disease characteristics, mostly based on clinical pathologic criteria and patient preference. And for many years, the only molecular driver for treatment decisions has been the RAS status. And that has now changed. We have gone from an approach where we would typically go from one doublet plus biologic to another doublet, and then if they have RAS wild type disease, we would offer them an EGFR. And that has changed because we are now looking at a broader selection of molecular characteristics where we recognize that not only are they drivers in colorectal cancer, but they're also actionable. So there's a therapeutic implication. And it includes not only things like deficient mismatch repair and HER2 and BRAF, which we're going to talk about, but also things like primary tumor location, which we understand to be a potential surrogate for these types of molecular markers. So what is the current accepted standard of care for biomarker testing in colorectal cancer? I think we recognize that for ascertainment of tumor mismatch repair status, or what is also referred to as microsatellite instability, immunohistochemistry is a fairly recognized and accepted standard. For genetic testing, it's the MAP kinase pathway that's still the most relevant in colorectal cancer. So we are talking about extended RAS testing. So that includes exons 2, 3, 4 of KRAS, NRAS, and now more recently BRAF V600E. We have also accepted, based mostly on data from the generation of RAS biomarker testing, that there is good concordance between primary tumor testing and testing of the metastatic site. And so, however, if a metastatic site is readily available, that may be preferred for testing from the perspective of understanding the current landscape, especially for patients with metachronous disease, whose disease has recurred several years after their primary may have been resected. The methods for testing, and I think we'll talk about this a bit more later as well, but you know, there could be single gene PCR testing, multiplex NGS, which has a lot of values in terms of economies of scale. You're trying to really not exhaust your tissue resources, and NGS offers an opportunity to do that. And again, more recently, comprehensive genomic profiling by circulating tumor DNA, or what we refer to as liquid biopsies. And I wanted to spend just a couple of minutes talking about liquid biopsies, because I think it's a hot topic. And I will start by acknowledging that in my country of practice in Canada, commercial ctDNA assays are not yet approved. So in the situations where we do testing, it's either on trial or through acquiring it from the US. But typically what when we talk about liquid biopsies, we're talking about tumor-derived DNA that has shed into the circulation, and looking for variants related to the tumor that can then be implicated in terms of targeted therapies. The indications for circulating tumor DNA are evolving. I think there's a great interest to see what the role may be for screening and early detection. But I think the two sort of most relevant to clinical practice in 2021 are evaluation of minimal residual disease after resection and comprehensive genomic profiling. So to what we're talking about today in metastatic disease. MRD is an interesting one. I wanted to spend a second on it because even though this isn't really in the metastatic landscape, the idea that when we ascribe adjuvant therapy after someone has had resection of a primary colon cancer, colorectal cancer, we know that we're doing it a bit blindly. We're relying on prognostic variables from the clinical pathologic information. But we have more and more data to suggest that the presence of circulating tumor DNA is a very strong predictor for recurrence. And many studies are ongoing to look at the value of assessment of circulating tumor DNA post-resection and how that may define practice. And that may also be relevant in patients with resected stage 4 disease, so stage 4 NED. So I think this is an area of active investigation. In terms of comprehensive genomic profiling, I think in colorectal cancer, where we have more ready access to tissue, typically for one-time profiling, I still predominantly use tumor testing, but there are circumstances where liquid biopsies can be helpful. There is an opportunity if tissue is not readily available, if we want to preserve tissue for some reason, to improve the turnaround time. Often it's in harder to detect cancers that, within GI, for example, like pancreatic and biliary cancers, liquid biopsies can be more impactful in terms of comprehensive genomic profiling. And then this idea of real-time ascertainment of genomic profiling. So, when we do an NGS profile, it's typically one time. In Canada, it's only funded for one time. You can't multiply do NGS on patients. And so liquid biopsies may offer a serial picture of the evolving molecular variants within a cancer. And this is relevant for things like if patients have previously received an EGFR inhibitor and develop resistance due to the emergence of RAS mutant clones, can we follow the decay of those clones and potentially consider rechallenge at a later time? And that's, again, also been the subject of many studies. So what I'm going to focus on for the rest of my talk is talking about actionable colorectal molecular subtypes. And I mentioned RAS before. It all started with RAS. So we know that the presence of a RAS mutation using extended RAS testing exists in probably about 55% of patients with colorectal cancer. And we also know that that presence does not open up a door for a new therapy. It actually closes the door to a potential therapy. So constitutive activation of RAS, through a mutated pathway leads to a less likelihood or no likelihood of response to upstream EGFR blockade. So EGFR inhibitors do not work in patients with RAS mutated disease. And this data was demonstrated in analyses of the trials that led to its approval in the chemo refractory setting. And so now, we typically recognize that the use of EGFR inhibitors, whether it's cetuximab or panitumumab, is reserved for patients with RAS wild type disease, and the presence of a RAS mutation would make them ineligible for such therapy. We also, in terms of looking at molecular subtypes, recognize that primary tumor location is also potentially a surrogate for predictiveness to EGFR inhibitor therapy. And we define the colon currently as right versus left. Anything proximal to the splenic flexure we think of as a right-sided primary. Those typically arise from the midgut, while left-sided colon cancers arise from the hindgut, which we believe is probably why we see a different molecular profile based on primary tumor location. It's relevant to our discussion today because we learned a few years ago from retrospective analyses, again, of first and second line trials that included chemo plus biologic, so chemo plus EGFR versus chemo plus Bev or versus chemo alone. And what was fairly consistently demonstrated was that the benefit from a survival standpoint for an EGFR inhibitor, even in patients with RAS wild type disease, is primarily limited to patients with a left-sided primary. And so that really led to a shift in thinking about upfront biologic choice, where if we're thinking about an EGFR inhibitor or bevacizumab in combination with chemotherapy, for patients with left-sided RAS wild type disease, an EGFR inhibitor would be associated with a more favorable survival. And for everyone else, so right-sided RAS wild type or RAS mutated disease, bevacizumab would remain the first-line biologic partner of choice. Moving on, but kind of still within the MAP kinase pathway, to talking about BRAF mutations. When we talk about BRAF mutations in colorectal cancer, 95% of them are BRAF V600Es, which is what we're really focusing on. There's a small proportion of non-V600 mutations, which do not seem to behave in the same way. But the presence of a V600E mutation in colorectal cancer occurs in about 7 to 10% of patients. They are a very poor prognostic factor. So many studies have shown that if you look at the outcomes of patients with wild type versus mutated disease, they have far inferior outcomes. And in earlier studies using BRAF inhibitors alone, it was fairly underwhelming in terms of response. And what was recognized was that in colorectal cancer, BRAF inhibition actually leads to feedback activation of the EGFR pathway. So you still have sustained MAP kinase activation. And so that led to an improved understanding that we need to target multiple nodes within the MAP kinase pathway. And so that understanding and subsequent phase 2 studies led to the Beacon phase 3 trial, which is what really changed practice. Beacon was a trial looking at the combination of cetuximab, an EGFR inhibitor, with encorafenib, which is a BRAF inhibitor, and binimetinib, which is a MEK inhibitor. And the question in the trial was comparing the doublet of encorafenib cetuximab versus the triplet, sort of MEK, BRAF, and EGFR, versus a standard arm of irinotecan-based chemotherapy with cetuximab in patients who'd previously been treated and failed on first-line oxaliplatin-based therapy. The primary endpoints were overall survival, and both in all cohorts and looking at in the triplet versus the control. And so what we saw when Beacon was reported and subsequently published was that if you look at the overall survival in the control arm, our patients don't do well when they progress on first-line therapy with a BRAF mutation. It was less than 6 months. There was a statistically significant and meaningful improvement in overall survival with the use of a BRAF inhibitor, but the triplet didn't do much better than the doublet. So the addition of a MEK inhibitor didn't enhance that survival benefit. And so what emerged from this was a recommendation of the use of encorafenib and cetuximab, the dual arm, in patients with BRAF mutated disease, previously treated, so in the second-line setting. This is the progression-free survival data from Beacon, again, sort of emphasizing that most patients the control arm progressed within 6 weeks. And in terms of response rates, we did see an improvement in response rates. It does look like the response rates were maybe a bit higher with the triplet arm, but not meaningful enough to be a true difference or to change the recommendation for the use of the doublet. Moving on from BRAF to microsatellite instability, this has been the talk of many congresses recently. Microsatellite instability in colorectal cancer has had a long history, initially for its role in ascertainment of Lynch syndrome, then for its utility as a prognostic factor in early stage disease in terms of risk of recurrence, and now in the metastatic landscape. So, we know that tumors that arise from microsatellite instability, which in all cases maybe represents 15% of colorectal cancers, they have a different behavior. They also have are associated with a high tumor mutation burden. And that the presence of that increased immune infiltration or increased tumor neoantigens lends itself well to the potential use of immune checkpoint inhibition as a therapy in patients with deficient mismatch repair colorectal cancers. And so there have been many phase 2 studies looking at nivolumab or pembrolizumab, both PD-1 inhibitors, in patients with pre-treated, so these are patients with chemo-refractory, typically metastatic colorectal cancer, that have consistently shown fairly high response rates, 30 to 40%. And indeed, we recognize that this is a tumor agnostic effect. So deficient mismatch repair present irrespective of tumor type seems to be associated with benefit from an immune checkpoint inhibitor. And so pertinent to our discussion for metastatic colorectal cancer, we heard in 2020 of the data last year from Keynote 177, which was a first-line trial, patients with metastatic colorectal cancer who were found to have evidence of deficient mismatch repair. Now, in stage 4 disease, it's maybe about 3 to 5%. It's uncommon. And those patients were randomized in a 1-to-1 fashion to either standard chemotherapy, basically dealer's choice doublet biologic, versus a chemo-free arm of pembrolizumab alone. There was crossover permitted for patients on the chemo arm who progressed, and there were dual endpoints of progression-free survival and overall survival. And so just over 300 patients were in Keynote 177. I just highlighted the fact that we do see a higher proportion of patients with BRAF mutations in this trial, because BRAF mutations do coexist in a higher prevalence in MSI high disease. And so in this case, almost a quarter of patients also had BRAF mutated disease. And this was the primary endpoint for progression-free survival, a statistically significant and very meaningful difference in progression-free survival. What was noted also is that there is a crossover at the beginning of the curves. So there were a proportion of patients on pembrolizumab alone who did not receive chemotherapy, who had a best response of primary progression. And the question has been trying to identify who are those patients who really need chemo upfront. But despite that crossover for the overall cohort, there was pembrolizumab was the clear winner in patients with dMMR disease. I mentioned earlier that crossover was permitted. In total, either on protocol or off protocol, about 60% of patients ended up having crossover. And we know when we see crossover in studies that that's going to influence the survival endpoint. And indeed, that is what happened when the survival data was subsequently presented earlier this year. We see that the overall survival still looks more favorable in patients with pembrolizumab versus chemotherapy, a hazard ratio of 0.74. And normally we would look at a p-value of 0.03 as being statistically significant, but because of the dual endpoint design and the alpha splitting, a p-value of greater than less than 0.02 was required. So it did not meet the threshold for statistical significance. But I don't think that has changed anyone's opinion of the data, recognizing that this was likely influenced by crossover. Objective response rates also higher with pembrolizumab. We can kind of see that in the waterfall plot, the proportion and the depth of those responses seems to be more meaningful. Overall response rate of 44% versus 33% with chemo. But we also see on this histogram in the blue, a higher proportion of PD, progressive disease, as best response. And that's what I was speaking to earlier in terms of that early crossover. So who are these patients who, despite having deficient mismatch repair disease, have really no response to immunotherapy? And I think that's kind of that will be the subject of future correlative studies. We talked about quality of life and how managing toxicity is important for our patients. We see that overall the toxicity profile very much favored pembrolizumab, which is in the green here, and toxicities were observed at a much higher frequency for patients with chemotherapy. We recognize that there are immune-related adverse events that we have to be vigilant for, but these are uncommon, and I think we all have a lot more experience today in managing immune-related adverse events. So the key takeaways for Keynote 177 was that there was a significant improvement in progression-free survival. There was a 3-year overall survival rate of 60%, which is really very meaningful. Pembrolizumab is currently recommended as the standard of care in patients with first-line deficient mismatch repair colorectal cancer. And a number of studies are ongoing now trying to look at what next. What about combination immunotherapy, immune checkpoint inhibitors combining PD or PD-L1 with CTLA-4, chemotherapy in combination with immunotherapy, and so this is the beginning, I would say. We talked about RAS, we've talked about sidedness, we've talked about mismatch repair, we've talked about BRAF. In the final minutes, I'd like to talk about things that are not yet, I think, in prime time, but I think very interesting in terms of future treatment opportunities for our patients. And so, we recognize that we're breaking down this pie chart more and more and subdividing, identifying important molecular subtypes in colorectal cancer. The one I'd like to talk about is HER2 amplification. HER2 amplification typically is mutually exclusive of RAS mutation, seen primarily in RAS wild type disease. And in that population, it's about 5 to 6%. So you could say about 2% of all comers. We know that there have been phase 2 studies looking at HER2-directed therapy approaches and have shown, again, in patients with chemo-refractory metastatic colorectal cancer, that the use of trastuzumab, either in combination with lapatinib or pertuzumab, can be associated with very meaningful response rates. Very recently, we heard of data from the Destiny CRC1. So this is a phase 2 study, but it is looking at the use of trastuzumab deruxtecan, which is an antibody-drug conjugate. It's a humanized anti-HER2 IgG1 monoclonal antibody that has a cytotoxic payload that is a topoisomerase 1 inhibitor. And trastuzumab deruxtecan has been studied in this phase 2 trial in patients with HER2 positive metastatic colorectal cancer. So the study designed for this phase 2 type trial it's not randomized. There were 3 cohorts, and cohorts were assigned based on the extent of HER2 positivity. So cohort A was the more traditional definition of HER2 positivity. For those of you who treat upper GI cancers, within the GI world, we have adopted this as HER2 positivity. So IHC3 plus or 2 plus and ISH positive. And the second cohort was IHC 2 plus but ISH negative, and the third was IHC 1 positive. So they were trying to see whether with this antibody drug conjugate, whether the extent of HER2 expression was influencing the magnitude of response, and the primary endpoint was overall response. It's important to, when we look at the response rate data, to remind ourselves that these are all patients with heavily pretreated disease. Most of these patients had 4 or more prior lines of therapy, and a third of patients actually had received prior HER2 therapy. So off-label trastuzumab, for example, had been received before they received trastuzumab deruxtecan on study. And so this is the waterfall plot reflecting the primary endpoint of overall survival in Destiny CRC1 in cohort A, and it was 24%. Again, if we look at sort of the depth of the responses, and we see that the small yellow arrows represent patients who had already had prior HER2 therapy, we see that that response is very promising. That kind of efficacy was not seen in the other cohorts. So the 2+ ISH negative or 1 positive. And in the progression-free survival and overall survival, we see for the cohorts B and C, there is really no meaningful signal of efficacy, and that is not, a patient population in which this approach would be recommended. So there's an ongoing first-line study with TDXD and using a different dose. So this is not yet something that I use in my practice unless it's as part of a clinical trial, but I think it is a sign of something to come. And then in terms of toxicity, one thing to remember with this class of drugs with TDXD, and my colleagues who treat breast cancer are already very familiar with this, but there is a unique risk of interstitial lung disease and pneumonitis, which requires close monitoring and care for patients. So it is something to be mindful for. And then finally, I think many of us are familiar with the increasing importance of TRAC fusions. So TRAC fusions are rare events. We recognize them to be oncogenic drivers. They are common in uncommon cancers and uncommon in common cancers. So in colorectal cancer, it's estimated that maybe less than 0.2% of patients may harbor an NTRK fusion in their tumor. And so it is a tumor agnostic finding, but the question is, how do we find these patients sometimes, without testing everyone, which we can talk a bit about. The clinical data for NTRK, there are 2 approved NTRK inhibitors in Canada, entrectinib and larotrectinib. I'm presenting the larotrectinib data here, but we see, irrespective of tumor type, in patients with pretreated disease, overall response rates of 70 to 80%. At ASCO GI about a year and a half ago, Dr. Berlin had presented the analysis within GI cancers. These are small numbers. It's hard to put a lot of weight on this with 14 patients. I think we still believe that it is tumor agnostic, but we do see that a proportion of patients with GI cancers can be found to have TRK fusions. There is a lot of literature, mostly coming out of the work from Memorial Sloan Kettering and their analyses of their impact panel, looking at how do we enrich testing strategies in these patient populations. So I mentioned to you, if I have 100 patients, and I'm trying to determine in whom should I be doing testing, ideally, and we'll talk about this, if NGS testing, including NTRK, was universally applied, this would be less of a question. But if we are in a resource-constrained environment, in Canada, the public health system, we have to be very diligent about how we use our resources. It's recognized that there is also the presence of NTRK fusions are almost always seen in patients with high levels of microsatellite instability. So if you're already doing mismatch repair testing, in those patients are the patients in whom NTRK testing would make sense. Furthermore, NTRK is mutually exclusive of RAS mutations. So deficient mismatch repair and RAS wild type disease, your likelihood of finding an NTRK fusion becomes 1 in 20 or 5%. And if you really wanted to be very focused, the presence of MLH1 promoter hypermethylation. So if that's something that your center did, you would further enrich the population. But I think a 5% hit rate would be very meaningful for testing, and it builds on testing we already do for mismatch repair and RAS. And so here, this is what 2021 looks like for us, for those of us who treat metastatic colorectal cancer. We've gone from this very linear approach, when I started my practice, of chemo doublet to chemo doublet to maybe an EGFR inhibitor, to really looking at, the molecular biology and trying to identify subtypes. For those patients with high levels of microsatellite instability or deficient mismatch repair, pembrolizumab is the first-line standard. For patients with proficient mismatch repair disease, chemo doublet or triplet is dictated by goals of therapy and patient tolerance. Choice of biologic, it seems to be dictated not only by RAS status, but also by primary tumor location. And we are looking at more increasing post-progression therapeutic options that may be available. Encorafenib and cetuximab for patients with BRAF V600E mutations, potentially HER2-directed therapies for patients with HER2 disease, and maybe EGFR rechallenge as well if we're following mutation clone kinetics with circulating tumor DNA. Both of these are areas of investigation. And so with that, I thank you very much. This is my city of Vancouver. This is my cancer center at BC Cancer, and I would be happy to take any questions.
Thank you.
Thank you, Professor Gill. My co-chairperson, Dr. Mohapatra. Dr. P.N. Mohapatra.
Sir, you can.
Hello.
Sir, you can invite Dr. B.K. Smriti ma'am for the panel.
Oh, yes.
I think
For
Dr.
a
Viraj,
panel case discussion,
excuse
I
me,
would like
Dr.
to call
Viraj had some questions for Dr. Gill. Dr. Viraj, you had some questions for Dr. Gill?
Yeah. Good evening, Dr. Gill. That was a fantastic lecture. So two questions that I had in regards to first for primary tumor location. We know it predicts poor response to anti-EGFR in first line. What's your take in subsequent lines if patient is wild type? Do you consider in your practice or it's just a no?
It's a really good question. I think I do consider it in my practice. I think that most of the analyses that have been done have been in the first line setting in combination with chemo. So if I'm looking at monotherapy in patients who now have like refractory disease, I do. Now, I will say I focused on Dirk Arnold's analysis where it was on overall survival. Interestingly, when they did that same analysis for response rates, they weren't able to show that same negative treatment interaction. And so sometimes the discussion will also come up of, well, what if we were trying to convert patients? What if we have someone with liver limited disease and the goal is response? I think it's not crazy. If your goal is maximal cytoreduction and you're talking about 3 months of chemo and someone has RAS wild type disease and they happen to be right-sided, I would still consider an EGFR inhibitor. It's a complicated landscape. We have data from EPOC sort of saying, oh, don't use an EGFR inhibitor, but I still do believe that in appropriately selected patients, there is a role for it. But I think for unresectable disease where patients, first line treatment, we're on it for 10, 12 months, I would limit it to left-sided.
Right. And the second question was regarding the use of IO in MSI high subset patients. Now, you did mention about 29% progressing outright within just 2 months. And we have few retrospective analysis for patients who were treated with immune checkpoint blocker in MSI high, that if you had not so high TMB, you didn't do well, whether it was colon or it was gastric. So if you had high TMB associated with MSI, then the line was flat, straight 100%. And if it was not so, it is just dropping at 3 months. What's your take on that?
I think it's intriguing. We don't yet have a good explanation for that primary progression. I think we want to, I think we are oversimplifying it a bit to say that mismatch repair is the only driver of response to immunotherapy, especially with a non-chemo backbone, like a chemo-free option. We don't, again, unless I've done a foundation medicine panel for a patient, we don't routinely for our in-house testing do TMB. But we know that even independent of mismatch repair, there is some data to suggest that high TMB is a predictor of response. The FDA has given a label to tumor agnostic TMB. But I think that the question also becomes, what is the threshold? So in CCTG, we did a trial in chemo-refractory disease and found that the use of IO therapy in MSS also seems to be influenced by TMB, but it seems to be a higher threshold. So not 10, but 28. My take is, keep doing the work. I think this is a question we need to answer. What would I do today if I saw a patient with DMMR, but a low TMB, and I'm trying to make a choice of pembro chemo? I think I would still, given if they have a low burden of disease, and I know that if I do a scan in 3 months and they're progressing, I'll be able to switch them over. I would still try pembro. I don't think I have enough data to deny them that opportunity. But if a patient has high disease burden and very symptomatic, I would probably start with chemo, maybe save the IO for later.
So do you get tempted to combine chemo with IO in such scenarios?
So, I mean, commit is going to answer that question, right? First line chemo with atezo. I would be, I would be tempted. I cannot so we have our funding. It wouldn't be funded for that indication. But I still think that that's a question that requires a study to change practice. And so I would still recommend monotherapy or chemo alone until we have better data.
Great.
Thank you. Great questions.
So Dr. Smriti, I think so.
It's the chairperson to invite a moderator.
Dr. Jainam, could you invite the panelists, please?
Yes, ma'am. I'd like to invite our chairperson, Dr. B.K. Smriti, ma'am. She's a senior consultant medical and meta-oncologist at Lilavati Hospital and Research Center, Asian Cancer Institute, Bombay Hospital, Institute of Medical Science, Mumbai, and Dr. Viraj Lavanya, sir, who is a consultant medical oncologist at HCG Cancer Hospital, Ahmedabad. And I also like to invite our panelist, Dr. Sandeep Ganguly, who is a senior consultant oncologist at Tata Memorial Center, Kolkata, Dr. Dipanjan Panda, who is a senior consultant medical oncologist at Apollo Cancer Center, New Delhi, Dr. Sushant Mittal, who is a consultant medical oncologist at Action Cancer Hospital, Delhi, Dr. Ganesh Nagarajan, who is a consultant gastroenterologist surgeon at PD Hinduja Hospital and Medical Research Center, Mumbai, and Dr. Ravi Tippeswamy, who is a consultant medical oncologist at Sri Shankara Cancer Hospital, Bangalore. So over to you, ma'am.
Yeah. I'd really like to congratulate Dr. Charlene Gill. That was a wonderful talk. And what I intend to do during this panel discussion is just to have a clinical experience through case-based discussions on how they would, put it into practice. So that is what I intend to do with this case-based discussion. So let me just load my slides. Yeah, so are they visible now?
We can see your screen.
Yeah. Well, Dr. Charlene Gill has set the stage for this whole panel discussion. As you know that there is an ever expanding number of genomic markers with actionable targets. But as you can see that they constitute about 21 to 25% of the total population of metastatic CRC. And then if you look at the prevalent alterations, as I mentioned, that 21% of them are targetable. And then it spans the whole spectrum from BRAF to MSI high. But majority do not have these actionable mutations. So still we have to go with, in those patients with the chemotherapy and the, our biologic agents. So let's come to the questions first. So let me begin with Dr. Sandeep Ganguly, that which biomarker do you test for? Which biomarkers do you test for? So can you take that question?
We are routinely testing for RAS, BRAF, and the MSI in our routine setting for metastatic colorectal cancer in the first line setting at least. These three biomarkers we are only looking for. And over a period of time, if the patient progress, then we are looking for the HER2 amplification also.
Okay. Would any of the other panelists like to add to this? What biomarkers do you test for when you get a patient of metastatic CRC? What about Dr. Dipanjan Panda and Dr. Viraj?
Yes, so I generally agree with Dr. Ganguly. That is the standard, but nowadays, because of the easy availability of NGS, we are gradually shifting towards NGS because the cost of doing a PCR-based test and NGS is gradually coming to almost similar. So if I do an NGS-based test, we also get to know the HER2 amplification and some of the other mutation upfront. But otherwise, what Dr. Sandeep says is right. RAS, BRAF, and MSI.
Yeah. Dr. Viraj, what do you have to say?
Yes, I agree. So we do RAS, BRAF, MSI, and HER2s on left side especially. I don't do HER2 on right side. And like Dr. Dipanjan said, nowadays in India, we have very cheaper NGS. So the gap is very less. So I have more and more patients going for NGS day 1 rather than at progression.
Okay. And Dr. Sushant Mittal and Dr. Rajan, do you have anything more to add?
No, ma'am, I would agree with this.
Wild type, then I would be tempted to check for HER2. If they're DMMR and RAS wild type, then I would be tempted to check for NTRK. So I think there are ways in which we can be judicious.
Ago and had a lung metastasis, and it was very difficult to biopsy, and we wanted to know the RAS status. So we did a RAS testing on liquid biopsy from an Indian test, not the Guardant one, but the Indian one.
So, well, it's not frequently used, as you said, that you have easy access to tissue, so it's rarely used, and at the moment it's mainly in the trial setting. So these are the biomarker testing, and we've already gone through this. So let me go to the next slide. I think the slides are not moving. Yeah. So now let us come to the case. So Dr. Viraj,
Yes,
this happens to be your case. So can you walk us through the case, please?
yes. So this was a very interesting case. I saw him during the second wave pandemic in India. He's a young male, 44, with no comorbid conditions and no family history of cancer. Presented with a cecal mass as seen on the right side bottom picture with peritoneal only disease. And at our center, because our center is a high-tech center, we often do a CT and MR fusion and try and calculate image-based PCI apart from the diagnostic laparoscopy. And PCI was slightly on the higher side, it was 20. So definitely the surgeons were not keen on going in first. The biopsy from the colon was mucinous adenocarcinoma, CDX2 was retained, and CEA was marginally elevated. Patient was MSS. Next, please. Next slide.
I don't know, it's not moving.
Yeah. And so we did a RAS testing.
I think, can I ask Dr. Jainam to load the slides?
Yes, ma'am. Yes, ma'am.
I don't
Yes,
know,
ma'am.
for some reason, it's not moving.
Yes, ma'am.
I will stop sharing.
Yes, ma'am.
I think you load it from your side.
So meanwhile, I can ask few questions to panel. So this patient ward was all RAS wild type and BRAF wild type. As you can see, we did it by PCR testing. So these tests are available for free by the pharma companies who give us anti-EGFR. They do free in our country. So this is a free test. So KRAS, NRAS, BRAF by PCR standard testing was wild type. So at this point, I wanted to ask a question. So everybody asked, like Dr. Dipanjan said, do you do NGS day 1? Is there any role of NGS on day 1? Or the second question is, would you deem this patient palliative from day 1? Or would you consider sort of neoadjuvant therapy and then convert him to CRS, if not high-tech? So we had Dr. Ganesh Nagarajan on the panel. So can we have his opinion?
Yeah, hi Viraj.
Hi.
Hi.
Congrats on your new job, sir.
Thank you. Okay, so this is a young chap. I think he's 44. I'm sure he's in excellent general condition.
Yes.
PCI 20, a little high, but still a mucinous, probably a low-grade kind of tumor. So not very good responders probably to systemic chemo. Definitely worth considering a cytoreductive surgery, either upfront or maybe at least a diagnostic lab to look at the mesentery, look at the kind of distribution of peritoneal disease before we finally make a choice. But I think I wouldn't completely label him as a palliative situation, especially because he's a young chap with not a very high PCI. 20 around, anything around 15 16 is still okay to go ahead. So it's borderline.
Okay. All right. Next line. And so the question, Madam, would you want to ask these questions?
So I think this role of NGS at diagnosis we've already answered. Most of the panelists, would go for PCR and where it's available, and now it's easily available and also cost effective. So then you go for NGS. And about this palliative and potentially resectable, I think already Dr. Ganesh Nagarajan has said. So which chemotherapy backbone would you use? I would like to ask Dr. Dipanjan Panda.
Yes, ma'am.
Whether BEV or anti-EGFR.
So that is a very interesting situation. I can see there are 4 issues. The patient is a right-sided tumor. The patient is only peritoneal only meds. The patient is MSS. And we need a good response, and it's a mucinous tumor. So considering that it is right-sided tumor, most probably I would go for folfoxirine with bevacizumab. But as Dr. Gill also pointed out, we have 2 major data. One is TRIBE, which use folfoxirine bevacizumab with oligometastatic disease. One is VOLFI, which is folfoxirine with panitumumab. Somehow my own experience is that when you want a major response, especially in liver mets, in a wild RAF, the anti-EGFR monoclonal antibody is a better option. Another issue with bevacizumab, or for that matter, any anti-VEGF monoclonal antibody, that post that use, at least for 6 weeks, you cannot do a major surgery. So in this case, if I have to use, say, folfoxirine with bevacizumab, maybe I'll use it for 4 cycles, then give folfoxirine for 2 cycles, and then assess for surgery. Other option, I still may use folfoxirine with cetuximab and look for response. But being a mucinous disease, the overall chemo response is limited. So I will discuss this issue with my surgeon and most probably take it to a tumor board. So both these options are available, and I mean, I can go with either, but being a right-sided tumor, most probably I will go for the first, that is 4 cycles of folfoxirine with BEV, then 2 cycles of folfoxirine, and then try for a surgery with CRS with or without HIPEC.
What about Dr. Rajan? Would you choose something else, or you agree with what Dr. Dipanjan said? Dr. Rajan, is he there? Is Dr. Rajan there? Okay, then Dr. Sushant Mittal. Dr.
Yes,
Mittal, yeah. Do you agree with this choice, or would you want to give something else?
Yes, I would like to counsel the patient or maybe the relatives that this might be a palliative setting, but in my mindset, I would like to use a full throttle NACT folfoxirine with bevacizumab and then see the response, so that relatives are at least prepared that they might not be converted to a resectable disease, but I would try my level best to convert them. And if we get converted, it's a bonus for us. So definitely I would like to use a folfoxirine with bevacizumab in such kind of a patient.
Okay. So Dr. Charlene, what would you choose? Would you choose the same?
This is an excellent case because it brings out so many nuanced considerations. I agree with all the comments of the panelists. I mean, he's young and it's peritoneal only disease. We know that those patients who are able to get to cytoreduction, we could debate the value of HIPEC, have a much more favorable outcome than just a palliative approach with chemotherapy alone. And I don't think there's one single right answer. I think it's really a consideration of what is the patient able to tolerate, what's our goal. So we want maximal response. And so all of the, chemo plus BEV has a role, chemo plus an EGFR, if the patient is going to be well enough to tolerate. Wolfie was an important trial, but a lot of toxicity, especially GI toxicity. So someone this young, it makes sense, but it's not really something I would think about for older patients. So in our practice, we would do the same. We would offer them neoadjuvant chemotherapy, combination chemobiologic, and then have them assessed by a diagnostic laparoscopy to see suitability for cytoreduction.
So, Dr. Gill, coming back to the question that Dr. Viraj had asked you about anti-EGFR therapy on the right side, the data is mainly in the first line, whereas in the second line, one could use anti-EGFR on the right side. But even in the first line, there are some instances where you cannot use bevacizumab. In which case, would you use just folfoxiri, or you would then go for the cetuximab or panitumumab along with chemotherapy as first line?
Yeah. I think Dr. Duplantin mentioned that the best cytoreduction is likely with a combination of an EGFR versus Bev, if you're thinking of biologic that's going to give you response. So if there was a contraindication to Bev, I would consider combining it with an EGFR. Again, for that defined endpoint of trying to see if you can get them to surgery, it makes sense. But I wouldn't continue the EGFR post cytoreduction, as you know.
Okay. So can you move on to the next slide? Yeah. So yeah, go ahead, Dr. Viraj.
Right. So what I did is I don't use EGFR on right side unless I have to convert and patient cannot tolerate a triplet. So as long as patient can tolerate a triplet chemo backbone, I usually don't use anti-EGFR. So folfoxiri plus Bev. So as you can see, the first row is the initial scan, and it's a diffuse peritoneal thickening everywhere. So on the first image is the primary, the second image is the top line, and the third image is around the liver. And after 4 cycles, there was not much response with a triplet plus Bev, only minor disease primary going down. And so we thought, let's do 4 more rounds with skipping of the 2 Bev, and we thought we will eventually open him up. And the peritoneal disease was slightly increasing, although by RECIST, they labeled it as stable disease, but we knew this boy was not responding. And CA also was from 47 to 58. And we were not happy. So very few patients, we see no response to a triplet chemotherapy, despite full bombarding FIFU. So another question what I had for Dr. Gill was, do you use FIFU 3 per meter square, or you do FOLFIRINOX 2.4 per meter square, or folfoxiri 3 grams per meter square?
FOLFIRINOX 2.4 is the preferred standard approach. I think that we talked about this before. This mucinous histology, it was an uphill battle to get a response regardless. And so I think a lot of us are looking at this not super surprised either.
Right. So Dr. Ganesh, would you now go in and do a DLAP and see? With the biology of the disease is not favoring us resection, what would you do?
Yeah, but as I said earlier,
no extra abdominal disease. There's still no extra abdominal disease.
Yes, I think my approach would have been to probably put in a laparoscope before we would start chemo. As I said, mucinous tumors, as we all agree, don't really respond too well to systemic. So I would have probably looked at surgery upfront. The other option, even now, I think if I look at these images, I don't think it's too bad to go ahead with a cytoreductive plus minus HIPEC.
Yeah, so I purposefully didn't show the image where it says it has small bowel mesentery involvement, because I know then you would have said it's unresectable. But when this patient eventually develops a small bowel mesentery metastasis, we did go in with DLAP, and it was deemed as unresectable. But what was interesting was, next slide, please. So at this point, I had nothing else to, I had no option, right? So I went ahead and did an NGS. And to my surprise, this patient had a BRAF V600E mutation, which was negative on PCR, along with TP53 APC and BRCA with VAF of 30%. So we know there is DNA mismatch repair alterations happening in colorectal cancer as well. Whether you should target them or not is a different issue. So based on this report, Dr. Smriti Madam, what would you think?
So, well, the question I wanted to ask was, actually, there's a lot of concordance between the PCR and the NGS. But one thing I wanted to ask you was, did you do a fresh biopsy or it was on the original biopsy?
Oh, this was a fresh biopsy.
Okay. So, Dr. Gill, how do you explain this discordance between the PCR and NGS? Any explanations for this?
You know, I think it's unlikely that it's like we do see that the concordance is high, but it's not 100%. And so I think I would be more puzzled if you said we sent from the same block, and then I would be, that would be more of a quality assurance issue. But in hindsight, this does actually further explain, like it fits the clinical picture as well and explains the resistance, as you said, to triplet therapy. There are a few cases where you don't get some kind of a response. But I think, it tells us where, and I mentioned earlier, we make the assumption of concordance, from the RAS era, and we're in a different kind of environment right now. So there is a tremendous value to thinking about if you're going to retest doing that on a fresh sample. It was a good call.
And another question I had is, would you ever think about targeting DNA repair pathway in colorectal cancer with PARP inhibitors?
So we have a basket, like an umbrella trial in patients with pretreated disease, and that strategy has been looked at. So I have had patients on study in that thing, but I would not do it outside of a trial.
So Dr. Deepanjan Panda, you would think that it's just that another site was biopsied that explains this. So what do you think of this? So then would you then target the BRAF? Dr. Panda?
Yeah, I can see. Normally in RAS and RAF, the concordance is very high. So, but in this case, if you are getting a BRAF mutation and I have nothing else to clutch, so like a drowning man catching a straw, I might consider. The only problem is encorafenib is not available in India. Yes. So you can use the other BRAF inhibitors, although we do not have the data. So we have dabrafenib available with trametinib. So if you do not have encorafenib, you can try that. I do not know the answer. Maybe I need to go to a tumor board and get the wisdom of my other colleagues. But as I say, since the chemotherapy, I have already used all the first line chemotherapy along with the drug which can work best, and it's not working, then there is no harm in trying.
Dr. Sushant, how would you treat this patient now? Okay, you have a BRAF mutation V600E. So then how would you go ahead with the treatment of this patient?
I would agree with Dr. Panda that it's a difficult choice, and the availability of the drug is also not easy. And I don't know whether this drug will definitely help the patient also or not. So maybe I would offer this combination to the patient and also counsel that it may work, it may not work.
Is Dr. Rajan there? Okay, Dr. Gill, is Dr. Rajan there?
Dr. Ravi is there. Dr. Ravi is there.
Yes. Perfect.
Sorry?
Ma'am, it's Ravi, Dr. Ravi Tippeswamy,
Dr.
sir.
Ravi, is he there?
Yes.
Is there.
Yeah, please go ahead.
Yeah.
Sorry.
Yeah. Considering the BRAF mutation, so in India, what is available is dabrafenib and trametinib. So giving dabrafenib, trametinib plus cetuximab is just a try again, as Dr. Sushant said, and we can try that option.
Dr. Gill, if you look at all the trials that have taken place, Then dabrafenib and cetuximab was mentioned as one of the studies, but has been withdrawn. What do you do in Canada? Is all these available?
Yeah, so it's a good question. You know, so in Canada, I'll start with that. Encorafenib is Health Canada approved, but not yet funded. So it is available through a compassionate access program. But you know, post Beacon, but prior to encorafenib approval, I have used dabrafenib and panitumumab. Ryan Corcoran's phase 2 data for the doublet and the triplet, you know, dabrafenib, trametinib, PMAB, or dabrafenib, panitumumab, was very close to sort of the data as phase 2 that we saw with EGFR inhibitor and BRAF inhibitor with vemurafenib cetuximab from Scott Kopetz. They all kind of had a 4.5-5 month PFS, which is not that different from what we saw in Beacon. So I actually think if we had access to dabrafenib and an EGFR inhibitor, it would be something to consider. I'm not sure I would add the trametinib. I don't think the MEK inhibitor adds a lot more.
Okay. So, Dr. Viraj, can you continue?
Yes.
So, what did you do to the, how did you treat this patient?
So the next slide, I was tempted to consider PARC, but eventually we went with dabrafenib, trametinib. Next slide, please.
Next one.
Yes, so we did panitumumab plus what used to be called as the GSK combo. So panitumumab, dabrafenib, and trametinib. But this patient was just on the mode of progression, and this patient progressed inoperable due to small bowel mesentery. And I think so we'll soon lose him. It's a very sad situation.
Okay.
Less than 7 or 8 months of survival, you know.
Yeah.
So I think let's move on to the second case. So we're quite clear. Next slide, please. So this was the Beacon study, which has already been shown by Dr. Gill. So let's move on to the next slide. And this is important that, you know, adding of the MEK inhibitor did not improve the median overall survival. So finally, next slide, you could use the Enco-Cetox combination. Next slide, please. So these are all the emergent BRAF targeted. And as I mentioned that, you know, dabrafenib with panitumumab has been mentioned. So I think that is what we would use in this patient and was used. Next slide, please. So now Dr. already answered this. So I think we just therapy without primary resection or primary tumor resection with chemotherapy. Next slide. That there was no real difference primary resection in this situation. Next slide. So this is the second case. And this is, I'm sorry, I could not get the films for this patient. This is a 60-year-old patient who was diagnosed with carcinoma cecum infiltrating the sigmoid, very large tumor, right hemicolectomy. It was a PT4N2B, 18 out of 25 lymph nodes positive. The MSI was high with MLH1 and PMS2 not expressed on the IHC. And of course, she also had a BRAF 600E mutation positive. And we know that, you know, almost quite a few of the MSI high patients do have concurrent BRAF 1600E mutation and also a PIK3CA mutation. So then there was this adjuvant FOLFOX was given to this patient. She developed cardiac issues. And this is one of the problems that we do face with 5FU in India. And so we have to be very careful in the first course. And so the 5FU was discontinued and the patient was just left with the suboptimal IROX treatment. And she developed multiple liver mets and some amount of peritoneal disease in 2019. And the CEA went up to 100. Next slide. So now going back to our panelists, Dr. Ravi, can you tell me what treatment will you offer this patient? These are all the options that I'm asking you to choose from. Dr. Ravi?
Considering the MSI high status, I would like to use IO, either pembrolizumab or ipi-nivo, but presently in India, I think availability of ipi is an issue. So I'll go with pembrolizumab monotherapy.
Okay. Now, what about Dr. Sushant? Dr. Sushant Mittal, are you there?
Yes, ma'am. I'm there, ma'am.
Yeah. So can you go ahead? Can you tell me your choice?
Ma'am, is the patient MSI high?
Yes, the patient is MSI high.
Then I would
It's
like.
also BRAF mutated, V600E.
But BRAF mutated also.
Yes.
Then I don't know which driver mutation would be helping.
Yeah.
Just like
considering the response Pembro has, and considering that the encorafenib plus cetuximab did not, there was response, but compared to Pembro, I think that is inferior. So in this case, most probably I would be going with pembrolizumab. Not the Nivo EP. First of all, for practical reason, EP doesn't have a support in India. Nivo EP is a toxic combination. So my choice here would be pembrolizumab single agent.
Any other, Dr. Viraj?
Yes, ma'am. So I've had 3 patients on IO monotherapy, having rapid progression. So I'm very skeptical about using MSI high as alone as a biomarker. So either I would be tempted to off-label use with chemo, or what I have done in a couple of patients is use Nivo EP, because that reduces my risk of progression. So EP is only 4 dose. So I think so that can be managed.
And it's a low dose as well.
And low dose, 1 mg.
Yes. So Dr. Gill, what would be your selection?
Yeah, so I think, in Keynote 177 with Pembro in the forest plot for subgroup analysis, the presence of a BRAF mutation did not mean lack of benefit. So I agree with the comments that I would favor an immunotherapy upfront approach. If I had access, I would do Nivo IPI as well. I think the Checkmate 142 data, response rates like 65%. It's four doses of low dose IPI at 1. I think in this scenario, given the behavior to date, I think that would be my preferred choice. We don't have access to Nivo IPI for this indication in Canada either. But then my second choice would be Pembro. I think in terms of BRAF mutation, I agree with the comments that it's a little bit underwhelming, the response rates with a BRAF targeted approach. And Anchor was a phase 2 first-line trial of encorafenib, cetuximab, binimetinib, and even in that, the PFS was not that different from Beacon. So I think I would go with an IO strategy up front.
Yeah, so IO would be the preferred choice. The first 2 were out of question. She already had problem with 5FU and she'd already received IROX. Now the thing, next slide, please. Already, everyone has mentioned that first line, you'd go for the IO. So also about the single agent and dual, it's already been answered. The question comes, how long should you continue? Should you continue till disease progression or complete response? And what happens when, suppose a patient gets a CR and you stop it, then what has come out from the data of Pembro, and also of Nivo? There are some important take-home messages as far as this question is concerned. So can I begin with Dr. Sushant Mittal? Dr. Sushant?
Yes, ma'am.
Yeah. So how, if you put on the Pembro or Nivo, how long would you continue the immunotherapy, till disease progression or complete response?
Ma'am, I would like to continue till disease progression.
Okay. Anyone else has any other thoughts on this? Dr. Ravi?
Yes, madam, I agree. As long as the patient is tolerating, I like to continue. If the patient achieves CR, then there are some data that we can give a break because the depth of response will be good.
Yes. And
so there is one point, madam, practical point. Although in most of the targeted therapy, we like to continue to the disease progression, but we know it's a significantly expensive medicine. What we have seen from immune checkpoint inhibitors, that because of activation of memory T cells, many of these patients do continue to respond once we have stopped them. So I do not have personal experience of stopping pembro once the patient achieves CR, but from lung cancer experience, I have seen that there are patients who, after a very good response, had to stop pembrolizumab because of financial reason, but they continue to respond for a significant amount of time, even after they stopped it. So I think this question is still open. And for patients who really have good response, I think they may have, I do not know whether it will be definite, indefinite for how long, but memory T cells do show that the response can withstand test of time for long enough. So that is one thing.
Yeah. Sorry, Dr. Sandeep Ganguly, is he there? Dr. Sandeep? Okay, then let me move on to Dr. Viraj. If
Yes,
you started,
madam.
how long would you continue?
So I tell patients that if you get CR, then I'll push to 1 year and then stop, of course, because of the financial reasons. But like Dr. Dipanjan said, I had a case of MSI high gastric, metastatic, and after 4 cycles, patient had grade 4 colitis. And patient already received a complete response, and she is already 1 year out. And I am not brave enough to re-challenge her. So her complete response is still ongoing.
Okay. Dr. Charlene, what is your approach in Canada? Like, when do you, how long would you continue?
I think, we are fortunate that we can kind of learn from our lung cancer colleagues and their experience with IO. I fully agree that the durability of the response in good responders post cessation of therapy can be quite long. Keynote 177 permitted up to 2 years of therapy. And we know that there were patients who had not yet progressed at 2 years. So if we're talking about evidence, I think we should be able to get some more data from 177 about what happened to those patients who discontinued after 35 cycles in the absence of progression. In my practice, it is funded until progression. But I think for a max of up to 2 years. But I also agree that if someone had a good response, discontinuing early, there's a justification for that.
Yeah. So actually in the NIVO study, they did have an arm where they continued up to CR. And then what they found is they continued to remain in CR, and the 50% who actually progressed could be re-challenged and controlled again with the reintroduction of nivolumab. Now, the other thing is markers of resistance. So any thoughts on that? Any of you? Like, for shortage of time, I won't ask individually. Dr. Sandeep, are you there? Okay, anybody else? Any markers of resistance? Because as you know that you still see responses in around 30 to 50% if you're 50% or 60% when you're using dual, but with single agent, it's around 30%. So we do have to look for markers of resistance. Any thoughts on that? Anybody? Dr. Viraj, Dr. Dipanjan,
Yes, madam.
Dr. Sushant, anybody?
So I think so from Keynote 177, we know that patients who had RAS mutations,
right,
they were the ones who were more likely to have early progression. And what I think is the TMB data will show, I'm sure will support this. If you have a low TMB, high MSI, it's very, very unlikely that this patient will see a response.
Yes, so actually the subset of patients in the forest plot, it was seen that, it's the KRAS mutated who did not respond. So going from that, if you had a patient, because after all, it's a very expensive medicine, would you offer it to somebody who has a KRAS mutation? Anybody? Dr. Charlene? Or
so I think this is a question that has been asked of Professor Andre, who is the PI, and so I think right now, based on the forest plot, a subgroup analysis is hypothesis generating. I would not deny a patient IO therapy based on the presence of a mutation. That's like, that's 40% of our patients. But, and they are looking at the correlative studies for immune markers of resistance and response. So right now in clinical practice, I wouldn't use that as a eligibility criteria. But I think the data that Biraj talked about in terms of, TMB, I think that's, I think that's where the conversation needs to be.
So the other thing, like you brought up the issue of TMB, the other thing that they have mentioned is about the immunoscore. So are any of the pathologists in any of the institutes doing the immunoscore? At least in India, I don't think so. But I stand to be corrected. Anybody? Immunoscore?
It's not.
No, ma'am.
It's not something. Yeah, our pathologists do routinely.
Okay. Okay. So can you move on to the next slide? I won't ask the last question because we don't have data on that. So now in this case, the patient was put on nivolumab because there was a patient assistance program in place for nivolumab, and same is not the case even today for pembrolizumab. So pembrolizumab becomes almost as double the cost of nivolumab. So although this was, first line metastatic, I had to put her on nivolumab for cost reasons, and she attained a remission. And again, due to cost reasons, it was a very good response. The CEA absolutely normalized. The scan showed that the liver metastasis had resolved, and she continued it for about 6 months. And after that, she has stopped it for obvious reasons. Again, what happens in India, but it's 9 months now of treatment, and she's still in remission. So again, some of the remissions are durable. Next slide. Next slide, please. So this is just the survival outcomes. Why we need to target MSI high is you can see on the left-hand side that MSI high metastatic tumors, the impact of BRAF mutation on survival. Those with a BRAF wild type do better than those who are BRAF mutant. So here, MSI high with BRAF mutation, you'd expect her to do badly. And that is what happened. And also with the number of nodes which are positive. And what is important on the right-hand side is that in MSI high tumors, the combination chemotherapy did not do better than single agent 5-FU, whereas in MSS, it was not the case. Next slide, please. So again, that was a rationale for using, the checkpoint inhibitors in such patients. So if you look at this data, I won't go into the details because it's been extensively covered by Dr. Gill. The next slide, please. So first line, there are 2 approvals. One is the dual combination and pembrolizumab. Next slide. And, this was just to show about the KRAS. And you can see over here that those who are mutated, did not do that well. Next slide. Next slide, please. So I think just cut out the next slide. This is already covered. Next slide, please. Next slide. So now coming to the third case, again, Dr. Viraj, can you go ahead with the presentation?
Yeah. Right. So in view of time, I'll just quickly go through the case. So this was again an interesting case and would encourage more discussion. Next case, next slide, please. So elderly male, 65, he was from Dar es Salaam, no family history, presented with a left-sided primary, an extensive multiple liver, lung, and bone metastasis on day 1. And the biopsy from the liver showed adenocarcinoma. CA was almost 1800. And this patient had all wild type MSS and HER2 3+ on IHC. And so this was one case where we did NGS on day 1, and it showed a copy number of around 7, ERVB2 amplification, copy number gain of 7. So here the question what I have for the panelists is, with HER2 positive, although left-sided primary and all wild type, would you be tempted to use anti-EGFR with chemotherapy? Madam, would you ask any of the panelists to answer that?
So can I ask Dr. Dipanjan? Would the HER2 +3, sort of prevent you from using an cetuximab? It's a left-sided tumor.
Sorry, ma'am. Can you ask the question again?
It's a HER2 3+. So would it prevent you from using cetuximab? It's after all a left-sided tumor. It's KRAS, MRAS, BRAF wild type.
No, I think we can use it.
Yeah, because Anybody else wants to comment on this?
No, it's the other way around, madam. Usually, if it is the RAS mutated, then we generally don't use the.
No, so that's why I said everything else is in favor of cetuximab. So what I want to know is whether the HER2 3+ influences your decision.
No, as of now, we will go ahead with.
Yes. Anybody else wants to comment on this?
Can we have Dr. Gill comment on that? Yeah.
So, again, this is one of those questions where there is some data to suggest that HER2 signaling, is related to resistance to EGFR inhibitor therapy. We find HER2 exclusively in patients with RAS wild type disease when we see it. But that being said, I think in clinical practice, like in someone who has this extent of disease, I would probably I would probably go with chemo-bev as my upfront choice. But if there was a contraindication to bev or I could not use bev, I would still consider an EGFR. But I think we have to be mindful of the fact that the likelihood of response may be less in the presence of HER2 amplification.
Right. So that was the question that we had a paper from Dr. Raghav and MD Anderson that the hazard ratio of using EGFR in these HER2 amplified tumors was 10, as high as what we have for KRAS. So next slide. So this is what I also did. Next slide. I went with chemo plus bev option, and patient did very well for 4 months induction, and then put him on maintenance bev for almost a year, which he took at local place. And he came back this year in a second wave pandemic with again a disease progression with CA very high. I re-challenged him with FOLFOX-CD bev because he took FOLFOX a year ago, and patient again had a progression within just 2 months. And so at this point, would you use HER2 targeting, anybody?
So Dr. Ravi, you want to comment, and then Dr. Sushant?
Madam, though we know that HER2 is positive, but from the data, we know that the PFS is on an average around 5 to 6 months, and generally it is in the later lines. So I would like to exhaust with all chemotherapy, bevacizumab, cetuximab, and then use HER2 inhibitors.
Okay, Dr. Sushant. Is Dr. Sushant there?
Yes, ma'am. I'm there, ma'am.
Yeah. So would you like to comment?
Ma'am, I want to know the radiological disease progression, was it significant or it was just a little?
It was significant.
Then I would like to change the therapy to pertuzumab and trastuzumab, probably.
Dr. Viraj, it's your case. Yeah.
Right. So we went ahead with HER2 targeting because I believed in that HER2 negative predictive value for anti-EGFR data from MD Anderson. So I was not going to use anti-EGFR in this patient. But unfortunately, even by HER2 targeting, initially we had a CA response, but radiologically within just 3 months, patient had again a disease progression. So question again is, would you still continue HER2 targeting or now bring in anti-EGFR?
Yeah, so Dr. Charlene Gill, can you comment now? So,
yeah, I think this is where if I had access to trastuzumab deruxtecan, I would, yes. I would, because, in the Destiny CRC data, even with prior HER2 therapy, these patients responded. Yeah, if I didn't have access to that, I would honestly be probably more attracted to trastuzumab, pertuzumab. I think the role of EGFR is, there isn't a right answer. We're kind of in the minefield here in terms of no data really to guide us. But the HER2/3 positivity, it's uncommon. I feel like I would want to lean in on that strategy a bit more before abandoning it, and would consider EGFR as my last line of therapy.
Okay.
Okay.
Yeah. So just move on to the next slide.
So that was the main thing. Yeah.
Yeah. So, I mean, we can just run through next slide, please. This has already been covered. So we've mentioned about the new options, but in India, we have just, we can just use the trastuzumab and lapatinib. And of course, pertuzumab is available. There is no data on the TDM one had failed in this. So, although we have access to that, we cannot use it here. Dr. Gill, there was data of, that TDM one failed in this situation, right? Or we don't have the data.
Failed in the situation of patients who've had prior trastuzumab lapatinib?
Yes.
What was the, I'm personally I'm not familiar with that data. When I was speaking to prior HER2 directed therapies, like in Destiny CRC, 30% of patients who enrolled in the trial with IHC 3+ or 2+ ISH positive had prior HER2 therapies, and even then, responses were observed, and many of those responders were patients with prior HER2 therapy. But if there's a separate report with lapatinib, I'm not familiar.
Okay. Next slide, please. And this is the last question, and I think we've already answered it, that when we come to NGS, if you're doing the RNA NGS, then you get a report on NTRK and NTRK testing as well. Next slide. And this is already covered. So next slide, please. So with this, I would like to, on behalf of the Mumbai Oncology Association, I'd like to give a special thanks to Dr. Charlene Gill. Make time on a Saturday and, took a very active part in this whole discussion. I would like to thank our chairpersons who've done a very good job of conducting the whole meeting. I would also like to thank all my panelists who had took part very actively. And also, I would like to thank Riverroot for managing the show. And I also would like to thank Lupin for giving us this opportunity to have an interaction on these new therapies. So I do thank all of you.
Thank you so much, everyone.
Thank you.
Thank you,
As
ma'am.
we move on to the fab end, I request Mr. Dharmender Singh, sir, to give the vote of thanks.
Thank you, ma'am. I think it was a wonderful evening with high on science and lots of insights on the management of colorectal cancer. My sincere thank Dr. B.K. Smriti for taking her out precious time and leading the entire show. Thanks a lot, ma'am, once again. And I also thank all my faculties. Have a nice weekend. Thank you. Thanks a lot.
Thank you.
Thank you.
Thank you.
Have a good weekend,
Good
Dr.
night.
Yeah.